Muted, sir.
Prashant, am I audible?
Yes, sir.
Welcome all to ISA online PG classes. Today we have got a very important PG class on anesthetic considerations on post-burn contracture. And I'm very happy to have with us Professor Syed Moied Ahmed from Aligarh, Uttar Pradesh. And it will be a slightly a change format rather than a lecture. It will be a case-based discussion. And the residents from his department will be presenting, and he will be subsequently moderating as well as taking over. So we have got two classes on airway management back to back. This is the first in the series. So I request Dr. Nishant to formally introduce Dr. Syed Moied Ahmed. Dr. Nishant
Right, sir.
is our coordinator for the class, and along with he will be shortly joined by Dr. Ankur Khandelwal also. So over to you, Dr. Nishant.
Thank you so much, sir. And it is an absolute pleasure to be able to welcome somebody of the stature of Dr. Syed Moied Ahmed, sir. Actually, he doesn't actually need much introduction, but he has been a very important person in airway management.
He will be shortly joined by Dr.
Okay, right, sir. So he's the professor and in charge of the ICU and former chairman of the Department of Anesthesiology and Critical Care at the Jain Medical College of Aligarh Muslim University. And we all know his interests in airway management, CPR, and the landmark paper on Cole's critical care. He's the president of societies of the UP and UK state chapter of the ISCCM, and he's the president-elect of the Uttar Pradesh ISA also. He's the editor-in-chief of Indian Journal of Anesthesia Central Supplement, and he has framed guidelines of the All India Difficult Airway Association, the All India Difficult Airway Guidelines, the Indian CPR guidelines. He has more than 110 international and national publications. He's won the Zakir Hussain Academic Excellence Award in 2022 this year, the WTG Morton Distinguished Professor Award this year 2022, the ISA Bhopal Academic Excellence Award in 2019, the ISA President's Appreciation Award in 2015 and 17. He's been felicitated by the Honorable Vice President of India and the Dr. Bhoj Raj Award for the Best Review Article of 2016. So he is a very respected and a very important member of the fraternity. Sir, every Monday the ISA has these ISA online PG classes, and in this we get speakers of national repute, and today also we have you as the speaker, and today we'll be having case discussions. So for the time being, all the audience will be muted, sir. And by the end of the talk, if they have any questions or queries, we can discuss them. And we may begin, sir.
Thank you so much, Dr. Nishant, and for that excellent introduction. I don't know whether I really deserve that, but anyway, thank you so much. Only thing is, of course, it's really an honor and a pleasure to be in this platform. And especially thanks to the ISA headquarters, especially Dr. Naveen, Dr. Giri, and his full team. I'm really it's a really thrilling experience for me. For the first time, I'll be presenting in this platform, and hope I would be doing justice to the topic. And I have along with me my two junior resident of GR3. One is Dr. Anjali and the other is Dr. Shivani. And both of them are doing postgraduate under me. They will be presenting a case. I'll tell you how my plan will work today. That is, we'll be presenting a case which is post-burn contracture in our department. And then one by one, I'll ask question to my junior resident, and they will be trying to answer those questions. So that is how we'll proceed. So I would request Dr. Naveen Malhotra and Nishant, if you could kindly let my resident share the screen a bit, because they'll be presenting the case. Will it be possible?
Anjani Shri and Shivani they can share it. What's their full name, sir?
One is Shivani Gupta. She's there. Shivani is the, actually she's I mean, yeah, that's it.
Yes, the slides are visible.
Good afternoon, everyone. Myself, Dr. Anji, and my colleague, Dr. Shivani, with our moderator, Professor Syed Moied Ahmed sir, we are here to present a case of postponed contracture, which was planned for release and cover in our very own department of anesthesia and critical care, JNMCH, Aligarh. So we had this patient named Pranjal, 20 years male, who was a resident of Uppercourt, Aligarh, and he presented to our hospital. And the presenting complaints were excessive scarring in neck and chest region, inability to look up, and tightness in the chest since 8 months. The patient was apparently well 8 months ago when he had burn all over the neck and bilateral hands with and chest region, approximately 30% of total body surface area due to kerosene explosion. Later, he developed contracture over neck, leading to flexion deformity of neck and keloid over the upper chest. There was also history of weight loss up to 10 kgs over 3 months after the burn, after the incident of the burn. There was, however, no history of difficulty in breathing, snoring, change in voice, epistaxis, and bleeding from oral cavity, or difficulty in swallowing. The patient's past history, there was nothing significant, as there was no history of diabetes, tuberculosis, or hypertension, no any other history of chronic disease and surgical intervention done in past. Whereas the personal history was normal, the diet was mixed, appetite normal, bowel bladder regular, and there was no addiction history. There was nothing significant in the family history as well. The treatment history, the patient was initially managed for a week in HDU and later in burn unit. And finally, the patient was discharged after 30 days of treatment post from the day of the incident of burn. Gradually, he developed scar tissue formation over the lower chin, neck, upper chest, and both arms with restricted neck movements and limited mouth opening. The general examination was done when the patient presented to PAC. Patient was conscious, oriented to time, place, and person, comfortably sitting with no signs of respiratory distress. The weight and height were measured as follows, and the BMI calculated. The presenting vitals were pulse rate of 84 per minute, volume regular and normal, rate regular and volume normal. The BP was 98/64 mmHg. Respiratory rate was 18 per minute. The patient was afebrile on sedation and present on room. There was no cyanosis, edema, icterus, or dyspnea. Now the local examination was done. Here we have also shown the picture of the patient. Then on inspection, was present. Thick fibrous bands running from neck to upper chest were present. Keloid present over the cell region. Hypertrophic scar present over lateral forearm, molar aspects, and there were no ulcer or any sinuses present over the burn area. On palpation, no tenderness was there over the scar tissue. The sternal notch was palpable. Thyroid, cricoid, cricothyroid membrane, and trachea, however, were not palpable. Now we moved on to the airway assessment part. The mouth opening was 2 fingers or 3 centimeters, as we can say. The modified Mallampati grading was done, and it was grade 4. There was no loose or any missing teeth present. The thyromental distance and sternomental distance could not be measured as there was fixed flexion deformity. The upper lip bite test was grade 3. The patient was unable to protrude mandible, and the TMJ could not, on the TMJ joint palpation, we saw that we could not insinuate one finger in front of tragus. The neck movement, there was restricted flexion, extension, as well as rotation. Now moving to the system examination part, there was no positive finding in the central nervous system, conscious and patient person. The pupil were normal size, normal reactive, and no sensory or motor deficit. The cardiac system was also within the normal limits. Respiratory system, however, there was bilateral equal entry, no added sounds, and no other abnormalities. Gastrointestinal system, the abdomen was soft, non-tender, bowel sounds were present. Investigations, as the patient presented us in the PAC, hemoglobin was 0.1%, total count 6,600. Differential granulocytes were more as normal. Platelets were 392,000. Blood sugar was also within the normal range. RFT as well as the ECG was also within the normal range, as we can see here. The chest X-ray was done, PAV was there, bilateral lung fields appear normal, the CP angles were clear, cardiothoracic ratio was within normal limits, and no tracheal elevation was seen in the chest X-ray. Then another important thing was the X-ray neck lateral, which fixed as you can see in this photograph. Now we summarize our case. It was a 20-year-old male patient with post-burn contracture over face, anterior chest, and bilateral hands of 8 months duration, with reduced mouth opening and fixed flexion deformity of neck, which was scheduled for elective contracture release and skin grafting under general anesthesia. Thank you.
Thank you, Dr. Anjali. Please stop sharing your screen so that I can share the screen now. So thank you once again, Shivani and Dr. Anjali. So today we have a case of post-burn contracture. And so this was the case, if you see. And so if you, to start with, what are the types of post-burn contracture? Either Shivani or Anjali, whoever would like to take this case. You have seen this contracture. Now, on the basis of this, how can you say that what was the type of contracture which you had, the patient had?
So there are 4 types of burn contracture. First is mild anterior contracture, in which patient is able to flex the neck, but inability to locate the object which is on ceiling. In type 2, moderate anterior contracture, in which patient is able to flex and can locate object on the ceiling, but there is pull in on the lower lip. In third type, there is severe anterior contracture, in which patient has fixed deformity, flexion deformity, and patient cannot get back to his anatomical position. In type 4, it is posterior contracture and contracting band at the back, which is preventing full neck flexion. In our case, it was 3 or 4.
Exactly. So this is primarily how you classify or how you make your type of grade, and then the patient belongs to the type 3 and type 4, right? So these are the types of post-burn contracture which we see. This is type 1, this is type 2, type 3, and type 4. Probably in between these two were patients which we had in this post-burn contracture. Now, depending on this, we've seen that patient now. What are the airway-related anatomical changes you expect in these type of patients? Can you tell me? You have already examined. So on this basis, what are the airway-related anatomical changes you found out?
So when patients like these present to a PAC, first when we start examining the airway, first we have to look from the nasal opening. The nasal opening will be distorted. The nostrils, the nasal airway will be distorted, and the oral anatomy can also be disfigured because of the burn. So this can lead to the changes in our management, how we proceed. Also, sir, there will be a restricted mouth opening, which is very important, and so there will be a contracture over the anterior part of the chest as well as the neck, which will lead into fixed flexion deformity, as well as restriction in extension also and rotation movements also. Next, sir, what is important for us is there will be TMJ joint movement will be reduced, and there will be difficulty in also assessing the surgical airway in these patients, which is very important for us if our first plan fails of securing the airway. Then so there will be stiff submandibular space, which will lead into difficulty in direct laryngoscopy because there will be no space. So these will be the major problems which will be there. Then will be scars will be there, so that can lead to difficulty in the movement of the neck.
So naturally, you have all these problems.
The...
Exactly, you can yes. Face these are the type of anatomical changes which you expect in this type of patient, right? So the next question, naturally, another things which you have we have to see is the distortion of the anatomical alignment of oropharynx and the pharynx and the trachea, because this is very important for us in certain situations where we would like to put a supraglottic airway device or we'd like to intubate these patients. Probably it will be very difficult for us to align this. And as you said very lightly, the cervical spine distortion, so there will be a fixed flexion deformity, right? So these are the things which we expect in these type of patients, and accordingly, you will always have a supraglottic airway device insertion and difficult intubation or difficult laryngoscopy and difficult surgical airway as well. So what are the salient points to be kept in mind while doing a PSC? What are the things which you have to keep in mind, that because you need to take this up for a surgery? On the basis of that, what are the things which you'd like to highlight in the PSC? Pre-anesthetic checkup.
So first of all, we will see for what surgery patient is presenting for. Either it is the same surgery for this contracture release or for some other surgery patient is presenting. Next, the burn. Which type of burn is this? Because management will vary according to if it is electrical burn or some because of any inhalational injury. These all will be important. Then the duration, we will see the duration of burn. Then we will see the extent of burn. How much involvement is this? Because it will be, we will see we can get IV access or not, or for monitor attachment. This is important. And then we will assess for airway, different airway tests. Pre-op airway tests we have. Those all will be assessed, and then we will decide the technique of choice for anesthesia.
Right. So very rightly said, we have quite a number of things to be noted in PSC, especially the type of surgery. Why? Because we know that what type of surgery the patient is coming, either for the release of surgery skin and going for a skin graft, or the patient is coming for some other surgery. The time and duration is very important for us, because depending on that, our drugs are becoming, implementation of the drugs become very important. And obviously, what was the cause of burn? Because if you know that the patient had an inhalational burn, probably we expect certain changes in the anatomically internal, especially the larynx and the trachea to a certain extent. And extent of burn is very important, as you said, the percentage of burn, because on the basis of that, we know that what variations will take place on the basis of neuromuscular junctions and the receptors. And again, that it also tells us whether it is involving your hand, feet, because if you're starting an IV line, becomes difficult. You start monitoring the patient also becomes difficult. And airway assessment is totally a different ballgame in this patient, because it tells you by the appearance only the patient will have a difficult intubation. And technique of choice of anesthesia depends on the basis of your airway assessment. And naturally, that becomes very important for us. So we'll deal that separately. And starting an IV lines, as I said, monitoring of the patients also becomes difficult at times. So very rightly said, these are the salient features we always like to highlight when we deal one patient. Now, how do you assess airway in these patients? Because that is a very important component when we see a patient like this. Obviously, there are so many things. By just look only, you can say that this is a difficult intubation, but we have to find certain things which should be where we can actually choose our technique on the basis of that. So now, how do you assess these patients on the basis of airway?
So whenever we are going to assess airway for any patient, there are 4 domains, the 4 Ds, which we have to keep in mind: difficult bag and mask ventilation, difficult laryngoscopy intubation, then the difficult supraglottic placement, and then difficult surgical access to the airway. So on the basis of these 4 headings itself, we will assess the airway for this patient also. But before that, first we need to psychologically prepare the patient, because this case is going to be a very difficult case for us as well as for the patient also, because mostly we plan for awake intubation, awake fiber optics. So we have to counsel the patient also. Then we move on to our assessment. For the first part is difficult bag and mask, where we have a predefined mnemonic, MONS. MONS, where M stands for any kind of difficulty which leads in mask placement, the making of seal. Then O stands for obesity, where we take BMI more than 26. Then A stands for age, which is more than 55 years. Then N is for no teeth, dentaless patient. And then S is for snorers. So this is basically difficult bag and mask. Moving on, we have also a mnemonic for difficult laryngoscopy and intubation, the Lemon law, where first L, we will look for the external anatomical features, which we usually see for bag and mask also and other things. Then E, for E, we evaluate. Then we evaluate the 3 points, the 3-3-2 rule, where there should be 3-finger mouth opening, the 3-finger distance from the tip of the mandible to the submandibular space, basically we can say. And then the 2 finger from the anterior laryngeal notch to the chin. That should be present. That is the adequate space we need for laryngoscopy. Then for M, we come for Mallampati grading. The Mallampati grading, as we know, grade 1, 2, 3, 4, that we will assess. Then O stands for any kind of obstruction, whether it is supraglottic or infraglottic,
So,
we have to know and classify.
Just Anjali,
And then N stands for neck.
do you think that
Yes.
you'll be able to assess Mallampati in this patient by seeing the patient? Is it possible to assess Mallampati here?
No, sir. In this patient, we cannot, because the mouth opening itself is reduced, so we won't be able to assess the Mallampati.
What about bag mask ventilation? Will it be possible to have a bag mask ventilation in this patient?
So it will be very difficult, because the mask, the seal will have a problem itself, because the neck is in the fixed flexion deformity position and the chin area is also involved. So we won't be able to make a proper seal. It is very difficult.
So what about the supraglottic airway device? Will it be possible to insert a supraglottic airway device in this patient?
Sir, if the mouth opening is more than 2 fingers, which was there in this patient, 2 finger was there, so we can go for supraglottic.
So naturally, what about the surgical airway? Is it possible to go with the surgical airway in this patient?
No, sir. Surgical airway is very difficult, because we were not able to palpate the cricothyroid membrane itself. So cricothyrotomy was out of option. It was not possible. Only if the scar release was done in case of emergency, then we can even think. But that is also very difficult.
So you said that it is difficult to bag mask, difficult to do laryngoscopy and intubate, difficult to put an supraglottic airway device, but probably
Yes.
since the patient has 3 fingers, we can take a chance. Difficult to go for a bag mask, surgical airway. So anything you are missing in this component? Because you said, sir, preparation, psychological preparation is one, again, a domain which has come out recently. And what about any other domain which you're thinking is very important for you?
Sir, at the end of surgery, extubation as well was very difficult. So that
Yes.
is also a thing which we usually miss, because we don't keep in mind the extubation part.
Naturally, always keep in mind that whenever a patient is having a difficulty to intubate, is always a difficulty to extubate. So you've got to keep that, safeguard that aspect as well. Very rightly said. So what are the various stages where you can face difficulty in airway management? You have already discussed that psychological preparation is one, difficult mask ventilation, difficult laryngoscopy, difficult intubation, difficult supraglottic airway device, and difficult surgical airway and difficult extubation. Now you said in this one aspect of surgical supraglottic airway device, you said that probably putting a supraglottic airway device is a possibility in this patient, because you said that 3 fingers mouth opening is there. So do you think if you put a supraglottic airway device, your device will be there, or is there any problem when you put a supraglottic airway device in this patient?
There may be difficulty, because larynx may not be at its anatomical position because of the injury and the fixed flexion deformity. Larynx may be.
Anything else, Anjali, you would like to say on this? Anything
Sir,
else?
there are also studies which say that the angle of the oropharynx and the laryngopharynx, that should be 90 degree for at least 90 degree for supraglottic placement, which we see in this case it's not there. It's very acute, hyperacute. So we won't be able to place supraglottic on the first hand very easily.
Excellent.
And even if it's placed, it will come out.
Yeah, that is one difficulty which you can face in this patient, unless you release the scar, and probably that can help you out. Okay. So what are the preoperative investigations required before anesthesia? You already said what are the most important preoperative investigations you think is really needed to get an operation done like this? Can you tell me?
Sir, first we will order for CBC, because we have to see for anemia, and then serum electrolyte for sodium and potassium, and RFT for baseline values.
Why do you
And
want to
then-
go for serum electrolyte in this patient? Why do you think electrolytes are very important?
So because potassium may be rise because of the injury to the tissues, and injury to muscle may cause increase in the potassium in the burn patient. And then if
Is it that the potassium level is raised, or it is because of something else which can rise the potassium level? Is it that you can expect a rise in potassium in these patients? Is it that, or it's something else?
So succinylcholine can lead to rise. So that is important. We need to know what was the baseline value, how much dose we should give, and by what we will rise the electrolyte the potassium levels.
Exactly. So naturally, that is why you got to go for an electrolyte, assessment. Anything, any other things? So you said electrolyte. You got to see the hemoglobin level, because these patients could be suffering from anemia because of prolonged illness and initial loss of RBCs because of burn. So that can lead to certain amount of anemia. So that has to be there. Anything else? Any other investigations?
sir, chest X-ray.
X-ray chest. What would you like to see in chest X-ray? X-ray
If
chest.
any tracheal deviation or
Okay. Anything else? Okay, so tracheal deviation could be a factor here, which you could like to see. Anything? Any other findings?
X-ray, neck, AP,
Yeah.
and lateral.
Yes,
and all.
so naturally that will let you know that what is the actually deformity in the cervical region. That to certain extent will let you know. Any other investigations?
Sir, we can also order for ECG.
ECG, right? So so these are the investigations where probably you'd like to go ahead with, right? And we've already done that. So what are the different options of airway management? Now let's come to this point. This is one of the most important aspect of this case, because this is where we will have a lot of difficulties. What are the different options of airway management do you think you have in this patient?
So always before proceeding for such type of case, we should have plans in our mind, the main plan as well as the back plans. So the plan A for this patient, the main plan was awake fiber optic intubation, preferably nasal, then oral. If we should prefer nasal, then oral. Although we can go for oral. The plan B was awake videolaryngoscope.
Why
There
do
are
you want
certain
to? Why do?
videolaryngoscopes that can also be used.
Okay. Carry on. Yeah. Plan B is.
So plan B was awake videolaryngoscope. There are certain videolaryngoscopes which can be used in reduced mouth opening and these kind of cases. Then sir, plan C was supraglottic airway device. If we were able to place, if there was adequate mouth opening, then we can place supraglottic airway device under inhalational. But factors being the same, whether we are able to place or not, then only we can go for this. Then sir, plan D was if these things were, if the awake fiber optic and awake videolaryngoscope were not possible, then we'll go for release of scar. We will ask the surgeon to release the scar immediately under low dose sedation or anesthesia, ketamine we can use, and then we'll proceed to secure the airway if needed. Then sir, even if this is not possible, then sir, we'll go for tumescent anesthesia. So the last thing, which is not often used nowadays, but we can use it anesthesia as well. But we should keep in mind that surgeon should be there, as well as senior consultant anesthesiologist should also be there throughout the our airway management.
So my point is, why do you want to? You said that you would like to go for, plan A was awake nasal fiber optic. Why do you think you would like to go for nasal? Why not oral? Would be a first. Would you like to prefer nasal, or would you like to go for oral? Or both?
The nasal is preferred. So we can do both, but nasal is preferred usually because of the, in this case, the axis was also distorted, the oral and the pharyngeal axis. So the entry of the fiber optic would have been a problem in itself, because the neck is in fixed flexion deformity, as well as we're doing awake fiber optic. So the chances the patient choose on the fiber optic itself. So that could be also avoided in case of nasal.
Okay, but you will be using local anesthetic, and then you will be using some airway so as to prevent the fiber optic to be chewed. So that is something which probably would not like to go ahead with. But so naturally that will prevent.
There's a chance.
So any other reason you think that nasal would be a choice? But again, nasal could be a difficult situation in this patient, because your nasal opening is reduced. If you see this, so if your nasal opening in this patient was narrowed, so naturally that could be a difficult scenario for you to pass your nasal fiber optic in that case, or you need to pass a smaller size fiber optic tube in this case, right? Fiber optic fiber scope. So would you, and a smaller size tube as well, because you will not be able to pass a normal size tube in this patient. Because, so what do you think? If nasal would be a good choice? Why? And if it is, yeah, if you say it's a choice, then you've got to stand why you'd like to go for a nasal than an oral. See, nasal is, the advantage of nasal is that patient acceptance is better, right? One thing. And the second thing is the nasal passage is, it leads directly to, or it helps you to pass your endotracheal tube, identify your larynx, visualize your larynx and pass your endotracheal tube. So that nasal passage, rightly, the contour is as such, it is in line with the larynx. So nasal in fiber optic becomes easier, but provided there is no narrowing of your nasal passage because of your fibrosis. So that is one thing which you have to keep in mind, because you cannot, if you pass a narrower size, smaller size tube, that can be also difficult for you, right? So in that case, it is both are an option for you. And oral fiber optic, of course, you can go ahead with it, but then you need to have a very good, local topicalization of these patients, local anesthesia. Now you said plan B. So if you fail, we'll come to that later on. So you said plan B. Plan B is awake video laryngoscopy. What video laryngoscope do you think is, would you think that patient can be? Because you have a, there are so many types of, say, supposingly a patient has a mouth opening of less than 3 centimeters. Say he has a 2 centimeter or 1 centimeter mouth opening. So what do you think would be a choice in these patients? You said video laryngoscopy.
There are type of laryngoscopy. Bonfils is one example. Another is Bullard.
Yeah.
And trach-lite, it may also be used.
Trach-lite is not a good option, because I'll tell you why. Because you have a fixed flexion deformity. You don't have any, because trach-lite is an indirect way of semi blind technique. It is a semi-blind technique, because you're being partially monitored or governed by the glow in right in front of the neck. So it's a semi-blind technique. So if you have the patient has a fixed flexion deformity, probably you'll not be able to visualize the glow. So in that case, trach-lite would not be a good choice unless you have an opening, unless you are given a scar. I mean, release the scar and that can visualize your larynx. But then that is not a very good option. So trach-lite is always not a good option in a patient who has a front of neck, postponed contraction, which is fixed flexion deformity, whether you cannot visualize your the glow, because you are being covered by the glow, which is a semi-blind technique. Supraglottic airway device, you said, obviously we have already discussed on this. The supraglottic airway device could be a choice because the patient has 3 centimeter mouth opening. But then again, if you see that it's difficult, because there could be a chance that the angle of the oral and the pharyngeal axis is less than 90, which does not allow the supraglottic to settle in its place, and that can let the supraglottic airway come out. But again, under deep sedation, you can go for a scar incision, release the scar, and you can allow the supraglottic to settle down a bit. So, but there are certain supraglottic airway devices where probably this could be a choice. Can you name them? Which does not.
Combi tube and LTS.
So LTS could be a choice where it will not, it does not depend upon your fixation of the cuff at the level of your larynx. So that could be a choice in these situations where the mouth opening could be narrow as well, and your supraglottic airway will also be rightly placed in these situations. So that again is a combi tube or a laryngeal tube suction sondum could be a choice in these patients. So you said release of scar under ketamine, and now this is again a option plan D, where you fail on this, and the patient can have a video laryngoscope after you release the scan, and then you can pass a supraglottic, which I already said. But again, the video laryngoscope could be, since you've released the scar, you can have a normal video laryngoscope as well. Now, this is again a very, in our days, we used to use this without Thrive. Of course, Thrive has come recently, but binasal airway. Do you have any experience on this binasal airway? You can use a binasal airway, and then you can make the patient spontaneous under deep inhalational, and then you can nowadays use Thrive as well, and then you can go ahead with the operation, release the scar, and finally you can go with an intubation as well. So this is again a option which is of course not an initial option, not the first choice, but then it can be a plan E. And finally, as you said, a tube center anesthesia will come into that later on. But very importantly, very rightly said that you always keep in mind that these are the techniques which probably you will not be able to you always need a very good guidance and a surgeon, because at times surgeon needs to give a good release incision so that you can release the scar and go ahead with your endotracheal intubation or supraglottic airway insertion. So this is how the plan works. So first is technique of choice is awake fiber optic. Then we have plan B is awake fiber optic with bond fields or bullets, video laryngoscope, and C is mouth opening. Now this is a choice. This is a place where you need to decide. If the mouth opening is more than 2 fingers, right, then you can, if you think that you need a definitive airway, mouth opening is more than 2 fingers and need a definitive airway, then probably insert a supraglottic airway device, and with the help of an intubating a fibroscope, you can pass a endotracheal tube if you think that definitive airway is needed, or you can go for the video laryngoscope as well. But if you think the mouth opening is more than 2 fingers and definitive airway is not needed, probably supraglottic airway device is only which can help you do the surgery. But if the patient has a mouth opening less than 2 fingers, then obviously if you need a definitive airway, where you don't need a definitive airway, then obviously CombiTube and LTS could be a choice for you. But provided the definitive airway is not needed. But if you need a definitive airway, again, fiber optic awake would be always a choice. The D option is release of scar and ketamine. We already discussed, and bilateral needle thrive and tumescent. There are other options which is very remote and not very used nowadays. But always keep in mind you need a surgeon. Now these are the devices just for the audience to see that we have Berman's airway, we have Williams airway, and we have also Ovasapien airway, which are used to go for a oral fiber optic intubation, which my resident was saying that probably the patient might chew, which is not possible in these situations. And just a question on this. Anjali, supposing we put a fiber optic, which space would you like to use? The middle space, middle terminate, or the inferior terminate? Which space would you like to use in this patient?
Sir, inferior terminate is preferred because it is more roomy, more space is there to insert the fiber optic, causing less trauma. Yeah. And
the bleeding is less and more space is there, obviously. And now these are the devices which we have. This is the bond fields which I was talking about. And really it helps even if the mouth opening is very less. Now, how would you prepare him for awake nasal fiber optic? Now, this is something which is very important for you to know. So how do you prepare this patient for awake fiber optic?
Sir, we first, there's also mnemonic for this as well, for awake fiber optic intubation, add TSP, which itself will elaborate all the steps. The first step is, it stands for counseling the patient, adequate counseling and psychological preparation of the patient. Then D stands for decongestion of the airways. We'll give the topical nasal drops. If we are going for nasal and oral also will decongest. Then the another D stands for the, we'll give the anti-salagogue medications. So it stands for the drying of the airway. We will go for drying of the secretions. Then sir, T stands for topicalization. There are various methods for topicalizing the airway with local anesthetics, including nebulizer, gargles, and sprays. And also we do spray as you go technique. That is also a different thing which we can do while doing the fiber optic. Then T is done. Then we'll go for S, that is sedation. Sedation in the newer guidelines, they say we have to keep the sedation as minimal as possible. And if we want to add any other agent, then a senior should always be present. Then sir, P stands for performing of the procedure, which the awake fiber optic. So this is the add TSP guidelines which we follow, or the steps for awake fiber optic.
And add TSP, I think P is also very important for pre-oxygenation and
peri-oxygenation.
So this is very important. Always keep in mind that whenever you go for an awake fiber optic, you got to go for a peri-oxygenation, or nowadays the term has come peri-oxygenation because it starts from pre-oxygenation, intubation, and post-intubation. So naturally, peri-intubation oxygenation is a very important term nowadays, which has come up. So as you said very rightly, we've already discussed on this. Now, why do you think you need to go for a drying up the secretions with glycopyrrolate? Is it needed?
Yes, sir. So because the secretions can cause a lot of problems, starting with the, if the secretions are pulled up, the vision will be hampered. the first
Okay.
problem.
Okay.
The another problem, if the secretions are there and we calculate the dose of a local anesthetic in total first, then we divide it for the spray, the gargles, and the spray as you go through technique. So if the secretion will be there, the dose will be diluted. So we will be giving an add-on dose to achieve the adequate topicalization. So by this we can reach the toxic dose, even if we can beyond the toxic dose. So these two are the main two important points for which we need to dry up the secretions.
Okay, very rightly said. That's good. So why and how do you want to sedate her? You said certain things there. So what is the newer guideline you said? Is there any guideline?
Sir,
Yeah.
Sir, according to the new guidelines, we will only sedate patient only if it is required. And if it is required, we will give the minimum dose, like remifentanil is given in the guidelines, and it is in 1 to 3 nanogram per ml. And next is if we are giving midas to sedate, then if second anesthetist should be present with us, then we can give midazolam.
Very nice. So if you see the newer guideline, that is Difficult Airway Society guideline, they have given a mnemonic on this, STOP, where S is a small s, which designates that S is sedation, which is a very minimal sedation, which obviously they are using remifentanil there, but we can use a low dose fentanyl, or you can use dexmedetomidine. So these are the drugs which you can use, but it has to be as low as possible, as minimal as possible. Very nicely said. So the next question is, how will you pre-oxygenate this patient?
Sir, we can use HFNO, high frequency oscillations, and the rate can be tapered from 30 to 70 liters per minute. But we have to remember peri-oxygenation is very important throughout the procedure, starting from pre-oxygenation, and we have to oxygenate the patient till we have secured the airway. So basically the term peri-oxygenation is very important in these patients. So
how do you obtain local anesthesia in these patients?
Sir, first of all, lidocaine 10% spray we will use, and at 3 places in oropharynx, tonsillar pillar, and base of tongue, and 20 to 30 sprays over 5 minutes. We can also use epidural catheter through the fiber optic, and we will give 2 ml drug and we'll wait for 30 seconds.
What is that? What is the technique known as? What is that? One second. What is the technique known as?
Spray as you go. Sagu technique.
Okay. And then?
And then, sir,
and
we can apply maximum dose of 9 milligram per kg.
So
we will.
Yeah.
Yes.
So you said that you will give 9 milligram per kg body weight, out of which you said 20 to 30 sprays, right? You would like to give.
Yes.
So it is how much? What is the percentage of that spray?
Sir, one spray of 10% is 10 milligram.
So you're giving 10%. So that means
yes,
you got to say that 10% spray, and one puff gives you 1 ml of
1 ml.
So 1 ml means how much?
0.1 ml is 10 milligram.
Yes, so 1 puff is 0.1 ml, which gives you 10 milligram, right? So this is how you got to clarify that. That means got to assess your total dose. So the spray is you have given already a spray, which is say 20 to 30 sprays. Anything else you'd like to do? So you go for say as you go. That means in the spray as you go. Also, that is another technique where you install. So how do you go with spray as you go? You said you will pass an epidural catheter. Then what? Then what will you do?
Then we will give, sir, 2 ml lignocaine, that is 2% lignocaine will be given here. And in 2% lignocaine, 1 ml contain 20 milligram drug. And then we will spray above at the vocal cord and below the vocal cord.
So before this, would you like to do anything else? Before this? Because
so we will nebulize.
Yes,
we can also nebulize a patient with 3 to 4 milligram per kg of the drug can be used in the nebulization of the patient.
Anything else, since you're passing through the nose? So anything else you'd like to do?
Sir, topical, we can also apply the like EMLA preparation or something.
So xylometazoline,
decongestion.
So decongestion you've already used. So you also can use pledget so as to give a local anesthesia at the tip of the nose or just at the level of the nose. So that can also be used, right? And then obviously you can go with a nasal inhalation, or we can say that nebulization primarily. That is one technique. Then you can go for gargle, because if you're going for an oral, you have to also go for a gargle. So that is possible in your patient because your patient had a mouth opening which is quite adequate. So gargle was quite a good chance of going for a gargle. So gargle, how much you give for gargle? How much? What was the percentage?
Viscous lignocaine preparation is used 4% only. We use 4% and we use 3 to 4 milligram per kg there also.
Yes, so exactly. So you give Dilucane viscous, which is 4%. You can use that also. And overall dose, because you've got to divide this dose, and the overall dose should not be more than
9 milligram.
9 milligram per. So that has to be kept in mind, right? So as you said, spray as you go, and spray nebulization gargles are this. And how much local anesthesia to administer, you always have, or you also have discussed. Now, one thing is very important is the percentage and the calculation. You said very nice, rightly, that 1%, 1.1 ml of 10% gives you 10 milligram of the dose, right? This is very important one, which is asked by the examiner. Anything else is, again, we know that 1 ml of 2% is equals to 20 milligram. These are the things which is being asked in the exam, so you got to keep in mind, right? And what is the last component, which is P? STOP. Yeah. How do you perform in this patient? What is perform in this difficult airway guideline?
So first, we will select the appropriate size of the tube, depending whether it's a male patient, female patient, whether we are going nasally or orally. In all the cases, the size of the tube will differ. Then after deciding the size of the tube, if we're planning for awake fiber optic, then ideally the patient should be in sitting, the patient should be in sitting position, and the operator should be standing in front of the patient. And the operator should be standing as such that all the monitors, infusion pumps, and the anesthesia, gas station, everything should be visible to the operator, as well as the patient should also be able to see the operator. We should also have devices ready for suction. There should be the suction port should be connected to the suction catheter, and suctioning should also be available. We can also do perioxygenation also by attaching.
Supposing we want to go for Anjali, supposing we want to go for a video laryngoscopy, what will you do then?
Sir, for video laryngoscopy, the operator, as with normal laryngoscopy, we have to stand at the back of the head end of the patient. So, the patient, the operator should be standing at the head end of the patient.
Exactly. So here, if you see the ergonomics, if you are doing an awake fiber optic, you are standing here facing the patient, right? And if you are doing a video laryngoscopy, you are standing here at the back of the patient, right, head end of the patient. So these are the two different things which has been brought by the optical airway guideline. So we already discussed this. Now, what are the troubleshooting in this? Now, what are the problems you anticipate while going for a awake fiber optic especially in a burn patient, because it becomes difficult for you at situations. So what are the what are the troubleshooting in this patient? So,
Sir, there will be blood view.
So why do you think there will be blood view? If there's a blood view, what will you have? What would you do?
Because sir, patient is taking spontaneous breath, which may cause fogging over the camera, and it will cause the blood view.
So what will you do then? How would you prevent that?
Sir, for preventing blood view, we will give the oxygen. Oxygen should be connected, or some demister can be used.
Yeah, so you can use 1 to 2 liters of oxygen, very low, so that it acts as a defogging. What are the other troubleshooting which you can face?
Sir, bleeding. There may be a trauma while we were operating the fiber optic. Then there may be bleeding at that part. Though for preventing that, if we had bleed, we will take out whole the fiber optic outside, and then we will suction. Then we will reattempt.
So one is you can go for a suction simultaneously, but again that will block your, because the blood will come out, which will block your view. That is 100%. So you take out the whole fiber optic and then wipe it and reinsert it. But then again that blood is already there. So how would you go ahead to, how do you prevent that to obstruct your view? How would prevent from obstructing your view? So any
Sir,
other? Yeah.
One technique is we can use the slit endotracheal tube while going in fiber optic, and then that slit endotracheal tube, while we will be inside, then it can be removed at the next endotracheal tube, which by which we are intubating, it may be passed.
So first thing is when you put a slit tube, you do a suctioning through that slit tube. Once the slit tube is right in front of the larynx, you do a suction so that the blood in the vicinity is taken off. Because if you pass a fiber optic after putting a slit tube also, then that will also again block your view because the blood is there. So do a suction through that slit tube, take out the suction, put your fiber optic, and now you can, now what will you do? How will you intubate this patient now? You have a fiber optic along with your installed endotracheal tube. So how would you do your fiber optic now?
So because it is slit, so we will remove this.
So you can split it and then remove that endotracheal tube, and then you can insert your endotracheal tube, which is there, right? That is again. So if you are not being able to identify the larynx, so what do you think the patient will have? Why do you think the patient will, you are not being able to identify the larynx? What will you do?
Sir, either the epiglottis is very floppy or big in size, so that is causing the problem. So we can ask the patient to, we can make the position of the patient lateral, and the patient also awake, the patient will cooperate. And also we can ask the patient to protrude the tongue. If the tongue is large and because of that, the epiglottis is also large, that can also obtend our view. So we can ask the patient to protrude the tongue. We can ask the patient to phonate also, that can also help. That will also move the epiglottis, as well as the vocal cords will become visible and they will be moving. So we can proceed our fiber optic through it. So these are the problems which are mostly caused.
So you can also see some gurglings also because of phonation. So that can also let
air bubbles can also coming from there.
So now you have intubated, now you put your fiber optic inside and your tube inside. Now you're not being able to remove your fiber optic. So what should you do?
So we will remove the whole fiber optic.
Yeah. So
outside, then we will reattempt.
So yeah, so you got to remove. Don't try to pull your fiber optic straight away. That will cause problem. That will tear your fibers and it will cause problem to your fiber optic. Now, one very important thing is you're being able to visualize you have already passed your fiber optic inside the larynx. Now you're not being able to pass your tube. Now, can you tell me whether fiber optic is under vision? Endotracheal intubation under fiber optic is under vision or not vision? Under vision.
Not vision. Sir, we are not visualizing at the time we are intubating the patient.
So always remember that fiber optic, you're doing it, you're visualizing your cord, you're visualizing your carina, but while you're intubating, it is not under vision. So supposingly, if you're not being able to pass your endotracheal tube, so what happens? How would you pass your tube then?
Sir, we will remove the fiber optic. Then we can use a small size tube or an armor tube can be used.
Okay. So that is armor tube will do you think it is going to help you if you're not being able to pass your endotracheal tube? That means what is happening to your endotracheal tube? Anjali, can you elaborate a bit?
Sir, the problem which is there is that there is a space being left between the fiber optic and the tube. So we need to obliterate that space. So either we reduce the size of the tube, we take a smaller size tube, or we can do one thing. There is big tubes are present, Parker tubes, parrot-shaped big tubes that we can use. So that we can be easily passed. Or we can do one thing more. We can rotate the tube to 90 degree.
Yes.
First we'll rotate the tube 90 degree. The bevel tip will come down. First, we'll try that attempt. If not possible, then we can remove the whole channel and change the tube, type of the tube.
Exactly. So the options are, one is you rotate the tube to 90 degree because the chances are that the tube is hitting the anterior commissure. So you rotate it so that it can come to the posterior commissure and you can intubate. This is one option. Second option is, supposingly if you inserted a fiber optic tube and the endotracheal tube, the space between fiber optic and the endotracheal tube is quite wide, then probably that is going to hinge at the vocal cord. So for that, you need to narrow that space. And narrowing that space could be done by putting an endotracheal tube, which is a narrower size, and then over that you can railroad your fiber optic, the endotracheal tube. That can be possible, right? And third is, obviously, you can use Parker's tube, which are dedicated tube for this type of problems to intercom. So that is what you can do, and but the problem in this patient is that you cannot go for a jaw thrust, which can lift your epiglottis. So you need to be very importantly, you need to ask the patient to phonate or to protrude the tongue, right? So these are the options which are there for you. Now, in case of unsuccessful tracheal intubation, what will be your plan of action? You're not being able to pass your endotracheal tube. As you said, the plan A, B, C, D. So how do you go ahead with it? Because the Difficult Airway Society has come up with that option as well.
So first, we will call for help.
Yeah.
Then we will stop and think. And while doing this, we have to give 100% oxygen to the patient. If we are giving any sedation, we have to stop that sedation. Then if we will decide at that point whether we can postpone this or we cannot. If we can postpone, it is not that urgent, we will postpone it. Then we if we cannot postpone it, then we will decide the other methods.
So naturally, if you think that the patient, if you first of all you call for an help, right? And secondly, once you call for an help, then you see you need to stop and think whether and give 100% oxygen, and you need to think whether you need to really need and maintain an airway. And if you think no, then obviously you can postpone it. But if you think yes, we need it because the airway is compromised and now we need to make the patient survive, either you go for a front of neck access, either you can ask the surgeon to straight away go for a release of scar and go for a front of neck access, or you can go for a you can go for light sedation or inhalation agents, and your option B, C, D, E are there. So they are all your options which can be come one by one, and you can go ahead with. And the rescue device is always there. Obviously, you can put a supraglottic airway device, right? So they are all you have to always keep that in mind. This is again a guideline which has been done. Now, what do you mean by tumescent anesthesia? Finally, let's come to this. Can you tell me what do you mean? So what does that term tumescent mean? What does it mean?
Tumescent means a swelling.
It's a swelling.
Something
right?
swollen. Yes.
So why do you need to swell this scar?
Sir, mostly nowadays it is outdated, not practiced much. Previously it was done. So basically it is a type of local anesthesia which we are administering, and it is used in such cases like this where there is postponed contracture. What we do, it is basically a mixture of local anesthetic. We take 30 ml of 2% lignocaine along with 1 milligram of epinephrine, the dilution of 1:1000. Then we take 1 ml of hyaluronidase, 1500 units hyaluronidase, and then we mix this with 450 ml of RL. Now, out of this mixture, up to 20 to 700 ml of this mixture can be used. It can be infiltrated in the space. Now, this large amount of mixture will cause swelling of the space, and which will this will help the surgeon to release the scar, tissue. And so this was done previously, and even nowadays also when we have a difficulty in airway.
So do you think that there could be any possibility of complications when using so much amount of drug at that area? Do you expect any problems? Is there any report which was there that these problems can be anticipated? One, any
overhydration can be there.
Yeah, overhydration. Anything else?
Local anesthetic, systemic toxicity.
So that could be a chance, and then it could be a chance of embolism as well. So naturally, they are the things which could be there. So naturally, they are not being used to that extent nowadays. So very rightly said. Now, what is the impact of burn on muscle relaxants? Because you need to be giving. Supposingly, you would like to give muscle relaxants in these patients, because once you've intubated these patients with fiber optic, you need to give muscle relaxants to these patients. So what do you think would be a choice? Would you like to, supposingly if you have a patient like this and you'd like to use non-depressing muscle relaxants, so what do you think would happen to this patient?
So there is increased dose of the non-depolarizing muscle relaxant because patient become resistant for that. The reason being there are proliferation of acetylcholine receptor in the muscles.
Why do you think why is it that there is proliferation of these receptors?
Because of decreased synthesis of a protein that is called rapsin protein. Rapsin protein, its synthesis decreased, which binds to these acetylcholine receptors, and while this protein is not there, there is much proliferation of these receptors, and and protein is not there to bind with them. So more muscle relaxant is needed.
So supposing this patient has come to an acute situation, acute condition, and yes, there you need to give a non-depressive muscle relaxant. Any other problem you expect in this patient?
Then also, sir, alpha-1 acid glycoprotein, its synthesis it also increased. and it binds to non-depolarizing muscle relaxant, so that also increases the dose of the non-depolarizing. The third reason may be the kidney, because kidneys may be over-functional in these patients. Washout drug is more, so this may also lead to the increased resistance to non-depolarizing.
Yeah. So in acute situations, when you're using non-depressive muscle relaxants, there also you can expect, though there is no proliferation of muscle, acetylcholine receptors, but in acute situation, because where we think in that situation, there is an increase in alpha glycoprotein, and that alpha glycoprotein binds with the non-depressive muscle relaxants, which prevents an active component of the muscle relaxants to reduce. So naturally, you need more amount of muscle relaxants. Very rightly said. These are the situations where obviously we'd like to go ahead. So supposing if you want to intubate with this patient with rocuronium, would you like to intubate with rocuronium or succinylcholine?
So we can go for rocuronium, is a better option, but we have to give increased dose, 1.2 to 1.5 gram per kg.
So why? Because see, in situations, if this is a difficult intubation scenario, would you like to use the long-acting muscle relaxants? Why not succinylcholine?
So because of the risk of increasing potassium, as we've already discussed, serum potassium will be increased up to like latest literature. Yes.
So you said that non-depressing muscle relaxants will be resistant. So is it flatly it will be resistant? Supposedly I have a percentage of about 10%, 15%. Do you think the muscle relaxants will be increased, resistant to increase? Or is there any?
This happens mostly when there is burn involving more than 30%
so
of the total body surface.
Exactly. So if it is more than 30%, we expect that there could be some amount of resistance to muscle relaxant. So what about succinylcholine? Why is it that we are avoiding succinylcholine? Why do you think we need to avoid succinylcholine?
So one thing, because in the acute phases, in the acute case, the risk, as we have discussed already, the risk of increasing potassium, the usual dose which you give, increase the potassium from 0.5 up to 1.2 milliequivalent. It can increase up to 13. Total, it can go up to 13, which will be very risky for the patient, can lead to arrhythmias as well as cardiac arrest. And the second thing, sir, because the receptors are proliferating. So for, as we have discussed, that for non-depolarizing, there will be resistant, but for depolarizing, which is succinylcholine, there will be high sensitivity, because the receptors are proliferated and the receptors will be exposed to the drug. More receptors will be exposed. There will be increased sensitivity.
So, so what do you think? What should be the time period when you should restrict your succinylcholine? Is it that flatly you should restrict, or is it some specific time period you have that you should restrict it, and after that you can use it? Or you can use it, you should not use it throughout the patient's life?
We cannot use after 24 to 48 hours of burn, and till 6 months, or it may up to 2 years. So yeah, we have to avoid succinylcholine.
So any non-depressing muscle relaxants which can be used, which is not being affected by the receptors. Any non-depressing.
Mivacurium.
Yeah, mivacurium. Why is that mivacurium? Why is it that mivacurium is not effective? Does not cause any problem? Because mivacurium
is the degradation of.
Yes, mivacurium is degraded by what?
So plasma cholinesterase.
Yes, so it is degraded by plasma cholinesterase. So naturally, that is why we are not being concerned about that. Now, any word about monitoring this patient? Any problem about monitoring? So what are the problems you anticipate in monitoring this patient? We've already discussed on this. Then monitoring becomes difficult. Why?
Yes.
Why?
So because of the extent of the burn, if the burn has included both the upper limbs, so there will be no space for non-invasive BP. The first thing which we are going to do. So for that, we can use invasive line, invasive arterial line. We can do. Then, sir, another problem will be for ECG electrodes as well. So there is a supposition of needle electrodes can be used because we cannot stick the electrodes to the skin. And sir, there will be also difficulty in venous access as well. So if we are not able to get any venous access, then cut open procedures in these patients.
So, word on how would you like to extubate this patient?
Sir, according to IDA guidelines, if we will go like if it is difficult 4Ds and 4S according to their guidelines, in which if it intubation is difficult or difficult bag and mask and difficulty because of any pre-existing disease or there was delayed recovery, then we have to
which
keep
category
a
this
so-called
patient?
difficult airway card training.
So which category this patient belongs to you?
Sir, this patient has difficult bag and mask, difficult intubation also we are anticipating. And because of pre-existing disease, the burn itself is a pre-existing condition which is causing difficulty.
Okay. So naturally, what will you do then?
Then, sir, first we will always keep ready the difficult airway card. Then, if the patient is fully awake and obeying command, we can extubate the patient. But the recommendation is we have to extubate the patient on AEC, airway exchange catheter, always. And then, sir, if and recruitment of lung should be done 100%. We have to take the patient on 100% oxygen first, then recruitment of the lung, and then extubate over AEC or fiber optic bronchoscope.
So if you don't have any AEC, anything else you can use?
Sir, Riles tube may be.
So naturally, exactly, because always remember that a patient who's difficult to intubate is always a difficult to extubate as well. So you have to keep everything in mind that this patient might need a reintubation, where obviously we should keep an option ready that how to intubate this patient. Though this patient's scar has been released and the patient has gone for a scar grafting, that is there. But suddenly, supposedly, if the patient you're not being able to intubate, then you will be really in a difficult situation. So always keep in mind. Now, one very important question that if some people, they're very fond, supposedly really intubate, you have missed plan A, that was your fiber optic, and you have to come to plan B, that is your rescue device, which is again video laryngoscope, where video laryngoscope also you don't have and bond fields, and you're not being able to use any other video laryngoscope. So plan C is your supraglottic airway device. Now, one very important question is, what supraglottic airway device would you like to use and why? You said that combi tube and LTS. Now, combi tube LTS, other than combi tube LTS, anything, because supposing this patient needs a definitive airway, where probably combi tube LTS will not be a good choice. So in that case,
intubating LMAs can be used.
Okay, so anything else? Intubating LMA is a choice. Of course, you can use intubating LMA through which you can intubate a patient. Anything else? Nowadays, the recommendations are always go for
second generation
supraglottic. Yeah. So second generation supraglottic airway device is the recommendation which you use. But obviously, through second generation also you can intubate these patients. So that is again, ILMA should always be kept in mind, and along with it, a second generation supraglottic airway device. So extubation has been done, as you said, that pre-oxygenate this patient with 100% oxygen, and continue oxygenation throughout the endotracheal tube, and recruitment of the lung is as per IDA's guideline. Continue for oxygen after extubation, and you can use high flow nasal cannula oxygenation as well, and then always extubate under AEC, right? So a bit of acute burn. Of course, we have some time with us, so that's why I thought I would like to cover some part of it, because examiners can go to acute burn as well if they have time, though these cases are usually kept as short cases. So naturally, they will not have more than 15 to 20 minutes time, but acute burn, fluid therapy is a very important component of acute burn. Now, what type of fluid would you like to give and what quantity? Can you tell me?
Single ringer lactate is always preferred. Balanced soil solution is ringer lactate or plasma light if it is available. We can go for plasma lights also. The quantities, there are various formulas. The most popular one being the Parkland formula, which we are using. There we calculate the fluid requirement of the patient in the first 24 hours, which is divided. We take the first, how we do the calculation. It is done with 4 ml per kg of the patient and the percentage of the burn. So the net quantity which we are getting, we will divide it into 2 parts. The 50% will be given in the first 8 hours and then another 50% in the 16 hours. But so this should not be very uniform. We have to keep assessing the patient, whether the patient is responding or not, whether there is overhydration or underhydration. If there is overhydration, we'll reduce the requirement by the fluid resuscitation by 25%. And if there is underhydration, then we have to increase also. So we have to keep a check.
What is the target? So what is the target? Which target you'd like to hit at?
So there are various parameters which can be used. Urine output being one, we have to keep 1 ml per kg per hour urine output, which can be easily done bedside also. So that can be used. Other parameters are there, but they are dynamic, maybe not present bedside.
Heart rate and BP.
So one very important question here, that you see when you're resuscitating this patient, right? So what is one very important aspect you have to keep in mind when you're resuscitating this patient? Because something happens after resuscitating this patient, especially if you see the history of these patients. Then, so what history is important for
The
you?
airway edema has to keep.
Sorry.
So the type of burn, airway edema, sir.
So
The
airway
airway edema can increase. Maybe this
Okay.
patient presented when the patient presented, there was no requirement for intubation, but after resuscitation, after 6 to 8 hours, the patient went into distress. So we increase the edema. So we have to look for the cause of burn. If there is any signs of inhalational injury, we should be very careful, and the intubation should be done on the first visit to the patient.
So
We
naturally,
should,
there
go for
obviously,
pre-hand.
yeah. So you have to keep in mind the stridor and hoarseness. If there is slight amount of stridor or hoarseness, you preempt this patient that the patient will have a difficult intubation, right? Or patient will go to total airway obstruction. So that is why you always preempt and intubate this patient before the patient lands up to a difficult airway or totally airway obstruction. So that is very important. We have to keep this in mind. And obviously, you must know what is the muscle relaxant protocol in these patients during acute burn. So these are some of the questions. So finally, just to sum up whatever you discussed. So whenever you see a burn patients, always keep in mind that what is the degree of burn in this patient. We have to keep very important, because on the basis of degree, we know that how do you classify, how do you make the type of patient which has come to you, type 1, type 2, type 3, type 4, or type 4 patient. So which type of the contractures are there primarily, that is important for you. And naturally, on the basis of this, the changes of the drug metabolism is very important, because muscle relaxants are one of the most important component which we keep in mind. The electrolytes are very important for you, and the fluid resuscitation in acute conditions, they are important for you. PVC neck is always important component. Is there are difficulties in airway management depending upon, again, the type of contraction. So type 1, type 2, type 3. Type 3, type 4 are difficult, really difficult airway, and you have to assess the difficulty and keep your plans ready. Plan A, B, C, D, E, whatever planning you're having. And the plan is always, remember, plan is awake fiber optic, whether it is a nasal or an oral. And you have to now, secondly, you've got to keep in mind that how to go ahead with the nebula, because your awake fiber optic will always be successful depending upon your topicalization of this patient. Means anesthesia component is very important. How do you have anesthetized? And you've got to be very patient, give time for anesthesia, because without that, probably will not be intubate this patient. So that is very important whenever you try to go for an awake fiber optic, whether it is a nasal or an oral. And the other options which are there, rescue devices are there, which is again a supraglottic airway device. But depending upon your type of contracture, it becomes difficult at times. And then tumescent is the final, which is nowadays not being used to that extent. But as per the examination point of view, they are being asked by most of the examiners at times. So administration of local anesthesia and the pattern of blocks, means how do you go ahead with the technique of block, means whether you go for a gargle. So overall dose, you've got to calculate. You've got to divide that dose according to the route of administration, whether it is a nasal spray or whether it is a gargle or whether it is a topical spray, or you have to see as you go technique. So all has to be collectively calculated, and maximum dose you can give is 9 milligram per kilo body weight. And these doses, the spray which you're giving, you need to know that dose what you're giving, because that is which is being asked, and you'll be calculating the dose on the basis of that spray. It is about 0.1 ml, which gives you 10%, gives you 10 milligram, and 1 ml of 2% gives you 20 milligrams. So you've got to calculate the whole dose, and then you got to administer. But everything, very importantly, always remember at TSP, because that is got to prepare the patient psychologically and at the same time physically as well, that when you go for fiber optic in these patients, the preparation of the patient is very important. Always remember that even if you have intubated the patient successfully, there could be certain situations of troubleshooting. So those troubleshooting could be always kept in mind, that how you can overcome those troubleshooting. So those options should be available to you. And then after finishing the case, your extubation is a very important component which you have to keep in mind. How do you extubate this patient? So thank you so much. to the viewers, and thank you and wish you all the best for your forthcoming exam. Any questions you would like to, I think I would stop sharing, and we can go ahead with the discussions. Any other questions which can be asked?
Yeah, thank you so much, sir. Thank you so much. And I'd like to thank both your team members also, Dr. Shivani and Dr. Anjali. They've been very confident, and it has been such a useful talk. I think there is nothing that the postgraduates will be asked of this topic because of the extensive nature. And because it has come from an expert in the field like yourself, sir, I think it will be very, very useful for all the postgraduates. We always encourage the listeners to ask any questions if they have any in the chat box. And I believe because it has been such a nice lecture, such an exhaustive one, that there are no questions as of now, sir. But because I have been looking forward to this lecture for myself also, sir, and there is this, I saw a slide in your lecture where you mentioned binasal airway with Thrive. So how do you do that, sir? I mean, just for my benefit here.
Yeah, actually, see, binasal, initially when we were at young age group, means when we are in the initial period of our training, in fact, we were assistant professors and all. During those days, we did not have, let me tell you, fiber optic, right? And we did not have that much amount of supraglottics as well. So we used to do the temporomandibular joint ankylosis along with this the bond contracture with binasal airway, and making the patient on spontaneous inhalation with especially halothane to a certain extent, and then get the cases done. Now, after Thrive came in, the Thrive gave us some additional input or benefit is that you can oxygenate this patient at a better situation, better status than what we were doing initially with the help of our just patient being spontaneous with this inhalation agents. So Thrive is something which is primarily to oxygenate this patient, but it is not going to help you as such to anesthetize the patient, but it's just to help you to oxygenate the patient in a better way, because it develops a CPAP of around 5 to 10 centimeter of water. So oxygenation becomes helpful. Otherwise, binasal airways along with inhalation agents would always be a choice for spontaneous ventilation in these patients with release of scar. So that is the technique. Thrive is primarily for oxygenating these patients.
So just out of curiosity, do you attach the Thrive prongs inside the nasal airways?
Yeah, you can use it. You can use it, but the only thing is probably that pressure which will be there right at the front of this, which will be pretty high. So you can lower down your the oxygen flow. That will prevent your waste of oxygen. The primarily why you need to do this is because you decrease your level of flow, that is 30 to 70 liters. Actually, you don't need 70 liters. You can reduce it to 30 liters, and that can itself reduce, generate a pressure of 5 to 10 centimeter water. So this is how you can go ahead with it. Or you can remove your binasal airway and go with a nasal prong as well. But then binasal airway, we usually put it, we can put it, in fact, because that will help us. That used to help us initially in those days to make the patient spontaneously ventilate and under inhalation anesthesia. That is what.
Right. Dr. Sanchita Sarkar wants to know about some books which you could recommend.
Okay, I have one book with me, which is always I keep it along with me. That is a book which we started with way back in 2006-7. In fact, we started with that book. That was Dr. Rashid Khan's Airway Management. Now it is the 7th edition which is running now, and 7th edition has a lot of incorporation there. The recent things which have been incorporated in 7th edition, and it's a really fully dedicated book for airway management. All the airway cases are there. Difficult airway cases are there. I would recommend that you can go ahead with that. Otherwise, there are so many textbooks which you can refer, but dedicated to airway is, I think this is one book which is always there. And of course, the Tata have also come up with some books on airway. I think that is also not a bad book.
Yes, sir. I can personally vouch for that book by Rashid Khan, sir. We have also studied while growing up. There's another. Sorry, sir. Yeah, there's another question regarding choice of muscle relaxant, rocuronium. They want to know whether that is the choice.
Yeah, rocuronium is, let me tell you, there's one very important question here, which obviously you've got to keep in mind. Now, if you take it in the broader perspective, that this is any difficult intubation. Let's not take it only pertaining to postband contracture. It could be difficult intubation of any nature. Rocuronium is always a better choice, especially in burn patients and in other patients as well, because of course in burn patients you need to increase the dose to 1.2 or 1.5 at times, depending upon the resistance of this drug. But rocuronium is preferred also because though we don't have it, let me tell you, to be open enough and to be honest enough, that we don't have that drug because it's expensive and not very easily available in India. We have the Supraglottic, which is a very good counterpart of rocuronium. So if you really face any difficulty in these situations, it can act. You don't need to wait for time. Time is not a constraint for this. You can immediately after giving rocuronium, you can give Supraglottic, which can reverse your patient. So this is one advantage which probably is not existing with the other drugs. So that is a rocuronium will always be preferable in any situations where you anticipate a difficult area. Yeah.
Right, sir. So I believe Supraglottic is not available. That is what. Yes, I think there are no more questions. Dr. Naveen sir, if you.
Nishant, now everybody is unmuted, so they can ask questions directly also.
Right, sir. So all the listeners are currently unmuted now, and they're all encouraged to ask any questions they have. And I'm sure sir will be more than happy. I would encourage them not to lose this chance. Sir is an expert and an authority on airway management. So I mean, you must clear your doubts.
We are still learning, Nishant. It's not that we are expert,
No,
but anyway, learning is, there's no end to learning, you know, and learning is a continuous process. We learn from the resident doctors as well. So naturally, I'd be really honored and pleasure to answer the questions. But again, I still learn from my residents. That's true.
But I must compliment, before Dr. Syed Moied Ahmed, I must compliment Shivani and Anjali for nicely presenting the case. God bless you and do well in your exams also. And thank you, Dr. Syed Moied Ahmed, for sparing your valuable time and joining us today for anesthetic considerations for post-burn contracture.
Hope I could answer the questions and give you in detail about the post-burn contracture, though it's not a very big topic as such, because it's a short case usually being asked in the question. But I try to give in detail about, I've dealt with the fiber optic intubation as well, because that is something which people don't, that is being left, because a local anesthesia component is very important in fiber optic. So I thought I can deal with that. This is a scope which I thought I could take.
And continuing subsequently, next week we shall be having the second class. It's always like that, Dr. Syed Moied Ahmed speaks, and then subsequently Dr. Rakesh Kumar takes the class on anatomy and physiology of the airway. So next Monday, you all at 5 p.m. for anatomy and physiology of the airway by Professor Rakesh Kumar from Delhi. Thank you once again, Dr. Syed Moied Ahmed, Dr. Shivani, and Dr. Anjali. Thank you, Nishant, for coordinating.
Thank you so much.
Thank you.